Hey guys, my name is Mavi and I've spent the last 14 years in the plastic surgery and beauty industry, working alongside top board certified plastic surgeons. Now I'm an independent patient coordinator who doesn't work for any surgeon. This means I have unbiased reviews for hundreds of doctors and I can help you achieve the look of your dreams, whether that's a supernatural or a video vixen. I use my professional and personal plastic surgery experience to help you look and feel your best. Join in on the fun as I talk to plastic surgery experts, friends, and real-life patients about all things plastic surgery. Should be fun. Hey guys, do I have the show for you today? I am so excited to have the MILF maker, the queen herself, Dr. Wendie Grunberg, on the show today, a fan favorite. Thank you for coming on.
Thank you for having me. I'm super stoked to be here.
You know, you are one of my fan favorites. I always get DMs about, oh my God, I love Dr. Wendie Grunberg. I found her on your show and I follow her on her page and I'm just so obsessed with her. Thank you for showing her to me.
Thank you. I appreciate that. I never know what I look like in other people's eyes. Like I heard like, you're not like a regular doctor. And I'm like, I don't understand what that means. So they're like, she's very eccentric. And I'm like, I get that. Okay, that part I understand. And I'm like, I know that I'm not everybody's like surgeon and physician and stuff like that, but it's nice to hear really good feedback.
They love you. The thing is, the ones that love you, and the ones that you're not their cup of tea, they can find somebody who...
I'm okay with that. Yeah,
there's shows for them. So I thought the topic for today would be so good because I know you are the breast revision queen.
Love.
And I want to talk all about all things breast revision, breast implants, breast fat grafting. We were talking about this in the DMs this week about fat grafting to the breast. And really, I have a list of questions here that I get very often. And I want to go all in. Let's go into it.
Let's go balls deep into this.
The first question is, how long do implants usually last?
So, good question. There is something that I say to every single patient who comes in. They're like, it's been about like 10 years and I still have my implants in. And I was like, is there anything wrong with your breasts? And they say, no. And I said, then keep them until there's something wrong with them. Generally, when people are coming to me, let's say for like a remove or replace, there's going to be, I think of like 5 or 6 things that are happening. 1, you know, a bigger implant, bigger boob, bigger implant. Let's change that out. 2, let's say you have implants at a younger age and your breast ages with you. So, as you go through like menopause, perimenopause, the breast gland is actually changing. It goes from something that's a little bit more dense and fibrotic to something that has a lot more fatty infiltrates, while the ligaments of the breast, called Cooper's ligaments, are getting long. What does that mean? You're probably going to have your breast, there's an implant in the back of it, I think, cascading off of your implant, and that's called a waterfall deformity. So you need a change. Your breast changed, so you need something different. Another thing that people come to me is like, this breast feels like it's a little bit higher, a little bit harder. You have capsular contracture. That's what people coming in. Going back to when does it need to be changed, I think there was like a company that was like, hey, we're going to give you warranties for about like 10 years or so. That's like that's good enough. And I think that sort of helped propel a rumor that there's a steadfast 10 years, 10,000 miles when it's not true. But you have to remember that an implant is an implantable device. It has wear and tear depending on how much you use it and just what's going on with your body. And that it's a device, so it can fail. So people who are not following, let's say, FDA recommendations, which are in 5 years after you first place your implants, you should get an MRI, and then every 2 to 3 years after that. How many of my patients actually do it?
Probably not that many.
No. Because it's an out-of-pocket cost, too. It's going to be like $2,500 for an MRI. You can get breast ultrasounds. Do they know what they're looking for? Maybe, maybe not when it comes to, let's say, an implant rupture. There are plenty of people's implants that I've taken out that have had a hole in them that they didn't know. With I feel like I'm rambling, but I'm just going to keep going. With cohesive gel now, when you squeeze an implant and you have a hole in it, the gel will herniate out, but then it'll come back and maintain its shape. So it's so hard to even see that. So an MRI would probably be the best thing. So I guess to recap, if they ain't broke, you don't have to fix it.
I love it. So I had a surgeon who would say, they're not tires. They don't need to be changed out every 10,000 miles. And
Right.
the 10-year came from that warranty. That was warranty for 10 years. So it kind of became this thought of patients. Okay, I have to get them switched out every 10 years. So
Yeah.
that is not true. Okay, this is a good one. What if you don't want implants
And you want a bigger breast?
and you want bigger breasts?
Fat graft all the way. So fat grafting is basically just like repurposing your body and like upcycling is what I tell people. So we are taking fat from one area in the body and basically liposuctioning it out, collecting it into a canister, let it separate out into like the super and internatant so the good ends up on the top. You take that and you can either put it into syringes and inject back little worms of fat. And then from there, you have to pray to the gods, both old and new, about how much of vascular ingrowth they're going to have to each little fat particle. So if you have let's say you're a heavy duty smoker and then you're just like in the middle of boobs, I don't want implants, and you're smoker and you're an uncontrolled diabetic, you can imagine, because diabetes and smoking affects very teeny tiny vessels, you are not going to have that much vascular ingrowth to your fat. So you'd better sacrifice a virgin or something in order to take it. So generally what's said is that about 30% of the fat, you can expect 30% of the fat to die like straight away. In some patients, it's a lot more. And in some patients, it's a lot less. For the life of me, I still don't have like such a great grasp, except for patients with a history of long-term smoking. You're going to need 2 to 3 rounds. You're going to need 2 or 3 rounds of something. Patients who lose weight after surgery, you're going to need to feed your fat cysts. You need to eat. You need to feed your boobs. And then patients who, I would say, again, diabetics, poorly controlled because it's a microvascular disease.
So how much, I know you said 30%. So let's see how we can explain it to our listeners who like need a little more visual understanding, maybe in like cup sizes.
A Coke can, is that like 250 cc's?
Yeah.
So 50 cc's. So just like a couple little sips of it.
Okay. So
even if you want to say like a quarter of a Coke can.
Okay. Are you seeing a lot of patients come in for multiple rounds of fat grafting to the breast?
When they're like to reconstruction, 100%. I tell every breast reconstruction, or if somebody comes in, they're born without a breast or some breast asymmetry, Poland syndrome, what have you, it's going to take me more than 1 round to get you to the cup size. And then one thing you always have to remember, fat adds volume, not structure. So if you're wanting that like upper pole fullness, you're either going to have to do one of 2 things. 1, get an implant to get that full upper pole, 3 things. 1, get an implant to sort of like push it, to have the breast tissue sort of come forward based on the implant. 2, get a really good push-up bra. 3, learn how to use breast contour and just sort of highlight your boobs and know how to put some makeup on. Those are your options.
So if you're looking for a lot of upper pole fullness, fat grafting will give you some, but it's not in the replacement of an implant.
Correct. But you can do both at the same time. I often do both, where you're like, let me just add a little bit of fat here just to make it like, you know, that perfection, that inner memory sulcus, the cleavage looks so good. Or if you have like a wide sternum and you have a little bit of breast asymmetry, and you don't think that when someone's like, oh, I put in, when I watch other people's stories, they're like, I basically just saved the day. She had a little breast asymmetry. I put in like, 450 on this side, and I put in like 475 on the other, and she's fixed. 25 fucking cc's. Like, that's not, like, what is that? It sounds like, to a layperson, like, before you and it was actually happening, I'm like, oh my gosh, how do they know how to do it? Will I ever know how to do it? And now I'm like, 25 fucking cc's spread out across the whole breast. When, when I look at a breast, I'm like, you are missing, everybody has these surgeries. I'm like, you are missing specifically, let's say, right in a quadrant. Why am I putting a slightly larger implant when the only thing that you're missing is in the right quadrant? Let me just stop graft that area on top of the implant and not be like, just save the day with 2 different size implants. Like, yes, I'm about to go and walk. I never understood that. It drives me insane.
Oh my God. I think I know who I've seen making.
They all do it. And listen, there is a time and a place for different size implants. Like when you're talking something more than like half a cup size or something like that. But when you're telling me you're finishing shit with 20 cc, get the fuck out of here.
And what do you think about when they say that you don't have to do different breast implant sizes because with the pressure from the implant, it compresses that fatty tissue anyway, and they end up the same? I've heard that.
I've done that, but it's for like slight asymmetries. And let me tell you what happens like a couple of years later. You're like, I should have added a little bit more fat. And like, who is telling you what is the rate of breast compression or how much breast compression is there? How are you measuring that? How are you how are you going to discern the gravitational pull on the breast, this expression behind it? Like, how is that happening? Am I missing something? Are you like measuring? Are you like going down? Like there is something to that. So let's have a patient with like saline implants. She has no idea what size she's in. She was a remove replace in masto. And I'm like, we have an option. I was like, we can sort of deflate your implants, and in 3 to 4 weeks, you can actually see the breast tissue sort of like fluff up maybe just a little bit. And then you can even see the skin not be as much under pressure, and it sort of jumps up a little bit. So you can get like really good nipple areola complex placement instead of putting them down and ending them with like star users or sunny side up type thing. But I mean, if you're putting in like 800s either side, no one's going to notice like a 50 cc difference. No one's even going to think of anything. But like, no.
Do you see a lot of 800s?
Yeah, I put them in.
How big is the biggest you've gone?
So 800s, that's actually the biggest silicone implant that you can place. I don't love saline at all. I rarely use it. I'm going to say I did maybe in the beginning, but let's say something happens to the saline implant and it gets a rupture. That is a surgical, what feels like an emergency for the patient because you're running around with like a flapjack.
Oh, yeah.
And in my head, I'm like, I got to get you in the OR within like 3 weeks, like as fast as possible. And sometimes like there's just, you try to do it as best as you can. So this takes like a week to get the implants, but you get a hole in your silicone implant and you got plans, go, do your twist. Silicone's not going anywhere. Come back when you're ready. You have some time.
With the saline, it's like, can we do this tomorrow? Can we fix this tomorrow? I have a wedding.
Yeah. I can't imagine. I mean, I've had a couple of like military patients help to me, and my staff knows if somebody says I have a ruptured implant, especially saline, I'm like, get them in yesterday so we can get them on the schedule, because having to go by inserts or I would still like off balance. I can. But biggest I've done is 800s. A lot of people have them. I'm doing some adult entertainers who have them, and plus fat grafting on top of them, just to get that little yeah, I love that.
Okay, wait. So now here goes one of my next questions. What happens to the implants when you die?
They're gonna stay with you forever.
They go with you.
Yeah, no one's taking them out. I mean, they'll be in
the coffin.
If you choose to be coffined.
If you choose. Or they'll be cremated, I guess, if you choose to be cremated.
They will be, yeah. they'll be burned, and it's at a high enough melting point where you're not even going to notice. There's this thing, so either if I die, I want to be made into one of those like tree pods, or I just saw something new where I could help a coral reef. They could like press you into like this thing to help rebuild coral reefs. That's what I want.
Wow. I've seen the tree pod, but I have not seen the coral reef. That sounds super cool.
I've always just, if I die, I just let it be thrown into the ocean so things can eat me. But now I can help like repopulate coral reefs. That's what I want.
I love it. I like the tree pod idea. I like the idea of like...
Very expensive.
Is it?
Yeah.
Dang.
I don't know why. It's ridiculous. It's as much as I think like a proper coffin, but just throw me in the ocean. Let someone eat me. Let me become detritus.
So now we're going to move into a little bit about the breast implant styles and something that I get asked all the time, which is above the muscle or below the muscle on the implants, and why pick one versus the other.
I love this because this is like part of my spiel that I go through with all the patients. So there are 3 different planes that you can place an implant. The first one is called subglandular. Subglandular just means I lift up the breast tissue and I put the implant underneath it. I do not do that. I do not offer that. I do not like that. I do like to fix it because what I find is that the most common complication is going to be capsular contracture. So when a patient comes to me and they're like, oh my God, I have cast on, I already know one of 2 things jump into my head immediately. One, this is before even seeing them. They probably have subglandular and they probably have a periareolar incision. We know caps con is due to bacteria. What does your breast do? Your breast's job is to communicate with the outside world. It has ducts and glands leading to a nipple. There's bacteria in it. It's going to get on your implant. It doesn't necessarily mean your implant is going to be grossly infected, but it could have a biofilm. Your body's like, shit, man, there's a biofilm here. There's bacteria. As a capsule, I'm going to protect my body even more and make a very thick capsule and wall it off. And then you're going to end up with a boob up here and then like a dangly little thing down here. Okay, so I don't offer that. Second option is something called subfascial, and that's like, I was about to do a really inappropriate thing. Everyone's like, oh, it's subfascial, it's so great. Is it great? Yeah. Do I like it? Yeah. Have I been doing it over a year or more? Yes. Have I had any problems with it? No. But that doesn't mean that problems aren't going to happen. So studies have shown when you do subfascial, your rate of capsular contracture probably by 10 years is going to be maybe like 25% at the end of 10 years. So what does that mean? You may have to have surgery. You may have to go on singular. You may have to going back to sacrificing a virgin, something like that. But there are certain breasts that I love subfascial for. One, if the gods have like created a body for you and you have a very wide sternum, so that means that if I'm going to try to put it under the muscle, the limits of my dissection medially, I think it'll help here, are going to be the sternal attachments of the pectoralis muscle. So if I have a wide sternum, I can only dissect here. Mind the gap, baby. That is a lot. That is a lot of space. And some people don't want fat grafting. And some people don't have a lot of fat. If you're very bony, a wide sternum, subfascial will probably do it. You put like a little gal with flex mesh in there and pulsaline, that'll help, help the capsule not be as far. The second one, tuberous breast. It's good. It's so good there.
Explain what a tuberous breast is.
So what happens is the universe can be cruel. So instead of having a breast that has like a nice nipple, a lower pole, and sort of like a teardrop shape, the guys are like,
you're too cool and everything else. You got to have something.
Yeah, they're like, so I'm going to give you a breast, but what's going to happen is I'm just going to have the whole thing herniated out and give you a huge nipple areola complex, and you're not going to have an underboob. You're going to be mostly nipple areola complex. And you're like, well, fuck. So I have like a couple of them that when I did them in the beginning in the dual plane. Dual plane position is basically what most people do. Most people use. That means like under the muscle. So when you hear a surgeon say, I put it under the muscle, there are a couple options. There's a total subpec that you can do. I don't do that because I see how they age and your breast is going to sort of cascade off and you're going to need another surgery. Or we can do something called dual plane. Dual plane means that the implant is mostly behind the pectoralis muscle, but when you release the pectoralis muscle from your ribs immediately to the junction with the sternum, the muscle sort of rides up a little bit. So the implant is mostly behind the pec, but also in the lower pole of the breast. So most of the time for my tumorous breast, I was doing dual plane and then plus back grafting the lower pole because I'm like, there is not enough tissue and I can already anticipate having something called a double bubble, meaning you have a nipple, which is just a little poof, and then a little bit of breast tissue. And then what you'll see is that there's just going to be implant. And sometimes when you release the muscle and sometimes the windows shade up so high, like the first patient I did today, like that thing recoiled and you couldn't anticipate it. What I was noticing, and this is in my patient population, I would do the tumorous breast, put in, patting myself with my head is so good. Maybe saying today. Yeah, I'm like, oh my God. So what would happen is the muscle would window shade up a little bit too high, and you would actually end up at the portion where the little bit of that poofy nipple was, and there wasn't enough fat that stayed. So you ended up creating that double bubble, and you ended up having to go back to the OR. And then I tried subsascial, and I'm like, fascia, if anybody ever cooks or something that you feel like chicken and you take that thin film off, it's something that's fascia. So you go in, you take that thin film off of the pectoralis muscle, and that's when the implant goes in. It is beautiful. It's hard. It requires to be delicate. There's a cursing and a learning curve that happens with it. But subfascial plane is beautiful. And also, it's a great option for somebody who's like, listen, I want boobs. I had to take care of, let's say, my parent who's 80 years old, and I have to go home and I have to lift them right away, or I'm active duty military. I need to be able to get back in. You don't have the muscle there. You don't have that risk of bleeding that can occur later on with stress of the muscle. So I think it's a really good option. And one thing I didn't say, so the rate of capsular contracture in the dual plane position at 10 years, I think literature quotes it's 10 or 11% only. So it's the lowest. So for me, I kind of now putting it back on the patient. I give them my whole spiel. I say, you need to go and do your homework. And then they'll be like, well, what do you want? And I'm like, do you want the higher risk of capspan for an easier recovery? Or do we want to think the long term? Because I'm here to support both of them. Unless it's that wide sternum or tumorous test.
I love it. So let's go into what is capsular contracture, because whenever we talk about breast revision, I think CapCon is one of the number one things women are coming in for. Also switching pockets from wherever they have it, if they have it subfascial, going to dual plane or...
So let's talk about the switching pockets thing. So it's just switching pockets just means a neo pocket. You can even lift up a previous capsule, and that's your new pocket. You don't have to sometimes you can take out the whole hassle. It depends on what the issue is. It has to contract. So implant goes in your body. Your body's like, what is this? I've never seen this before, and it does its job and makes this nice little protective coating. And that's called a capsule. The capsule doesn't hurt you. There is nothing wrong with it. Help keeping your implant in place. It's there for you. It also has a job, and its job is to protect the body against a foreign body, essentially, which is the implant. So let's say I'll use COVID for instance. I had a couple patients around COVID, when they had it, they were like, my boot feels weird. And all of my patients know as soon as something feels a little bit off, tell me right away so I can help like figure out what's happening, what it is, just like in breast tissue, this capsular contracture, the things you can do that to prevent you from getting back into the operating room. So you get COVID or you're gam in the nursing home, God forbid you get pneumonia, and it is bacteria. It can travel to your boob. So now you have a foreign body, and for some reason, bacteria knows that there's a foreign body there, and it's just chilling on the implant, and your capsule's like, something ain't right. So what it does, it goes through a nice, like, super thin, almost like see-through material, or whatever you want to call it, see-through film. It starts to get thick, and it can get as thick and sort of almost looks like a rind, like a grapefruit rind. It can be thick and hard, and it is painful. So there are different grades of Castron, and the worst one is grade 4, where it's hard like a rock with a cold breast. Not cute. When it comes to surgery, we talked about how highest incidence of capsular contracture is going to be subglandular itself, then subfascial, then dual plane. So if I go in and somebody has like rock hard capsules, it's coming out. Everything is coming out. The worst case would be somebody is cast on and they're in the dual plane position. Because now, not only are you taking the capsule off of muscle, which sometimes can be very bloody, you're also scraping it off the chest wall and rib.
So that's interesting that you talk about that, because how often do you have people come in and they're like, oh, but I only want it removed en bloc?
I've had 0 cases of breast implantillas in my practice that I know of. It's not saying that somebody couldn't have gone to another surgeon to be like evaluated for it, but I have 0 cases. Why? I think I educate a lot. 2, I think there has to be some sort of autoimmune component to it. Like, what if the patients who have autoimmune diseases, I'm just thinking about this logically. I'm like, I'm no scientist, I am. So if I put something in your body that's foreign and your body's already worked up in hyperactive overdrive, what's to say that you're not going to feel like shit because your body's constantly reacting to something that's inside of you? I haven't had one patient come to you and explain to them like logically about it, tell me that they want this like unblock thing. If a capsule needs to come out, I'm going to take it out without a problem. If it's easy to come out, but if the risk of taking a capsule out is going to harm the patient, for whatever reason, like what if it's like up and wrapped near like the vessels to the pec? I don't think leaving that little bit of capsule in is a bad thing.
When patients who are in the Facebook groups for BII, or just in those groups, whether Facebook or elsewhere, when they find a surgeon who will remove and says that they remove en bloc, that's where they all go. They put it in these groups, and that's where they go. So maybe that's another reason why you don't get a lot of requests for it. But in the last practice I worked before I left and launched the show, somehow we ended up in one of those groups, even though we didn't offer that, but we ended up listed on one of those groups, and we had a very, very large population of BII patients who were coming in requesting. They believed that the only way to get rid of the BII was to have the procedure done en bloc.
Yeah, I mean, I'm taking care of a couple patients who have had their implants removed by some en bloc things, and I gotta tell you, one that sticks out. Instead of taking we've done one surgery, I need at least 2 to 3 to fix everything.
That's why you're the breast revision queen.
Yeah, we're about to be on like 2, and I feel terrible. She was like I don't even understand what happened. It's almost like, so they did this en bloc thing, but her nipples are attached to her pectoralis muscle. And I guess if you demonstrate it, still the whole thing is sort of like inverted, and you can't even see her nipple. It's hard to clean.
Oh.
It doesn't look like a breast. This is somebody that needs multiple rounds of fat grafting. I told her, I was like, this is going to take me 3 rounds. We did 1 round. what we did looks great. I had to go back in and release some more scar because now there's a space to sort of go in and release instead of cutting like pectoralis muscle off of the back of the nipple areola complex. And then the third round will be like fat grafting again. So like there'll be 3 rounds of fat grafting to get her hopefully small C cups because she was left with nothing. It's almost like they took good breast away too. Too much. Way too much.
Gosh. I hate to hear that.
She had super severe symptoms where she felt like she was choking. And then once that silicone was out of her body, she's in a lot better.
I've had multiple surgeons on the show who also say what you're saying, that there has to be some sort of autoimmune component to it, that just how patients are allergic to gluten and this and that. Like there's logically, it makes sense for some patients to just have a reaction to implant.
Right.
Which is why a lot of women are trying to look for other options instead of getting implants. They're looking for fat grafting.
Fat graft all the way. I always tell my patients, how do I know if you're allergic to silicone? And they look at me and I was like, we try it. If you don't feel good, then we know that this is probably not a good option. But based on your medical history, I feel confident these are going to be okay.
Let's move on to my next question.
Okay.
Breast reductions with augmentation. To stage or not to stage?
Okay. It riddled me this. You're coming to me for a breast reduction and you're telling me you want me to add volume.
You know, this is what I had. I had one of these. Let me tell you why. So mine did not look, even though they were big, they did not look like my patients who got 500cc implants in them. And I wanted them to look like that. So we did a small reduction with lift, and we put in an implant to give me the upper pole fullness.
How many cc's is a small reduction? How many grams did they remove?
I think she removed maybe like 250 around.
Yeah, okay. So it's like a standard like Weiss pattern central like aspect and stuff. I feel like if somebody's coming to me with like a G or a K breast, I'm going to do a reduction. I'll probably place a mesh in so they don't get that pseudotosis from like skin stretching. I still don't understand you wanting me to add volume, and they'll probably come to me at a later time.
You know what? It's a little bit different because mine weren't G's or K's.
Right.
Those are like large breast reductions. Mine was like double D's. I was like double D. I'm still the double D, but now I have the upper pole fullness that I didn't have before, which is what I wanted.
So
I wanted them
to basically it's all masto.
Yeah.
Same time.
To stage or not to stage is the question.
Same time.
So
I would do it at the same time.
Let's go into why some surgeons choose to stage versus doing it at the same time. A breast lift by itself or a breast lift with an implant.
Because it's the number one case where based on the literature, where you're probably going to have to like fix something a little bit later on. Because you never know. Number one, you do a lift, you're like in the OR, you're like, this is the greatest lift I've ever have done. And then something happens in healing, and you're like, I swear to God, I measured these nipples 85 different ways from Sunday. And one of them just looks a couple millimeters off, or one of them just looks weird, or like, damn, like that just looks weird. So you add an implant on it. So now you have to guess after you do a lift where the nipples should be, but now you're adding weight. And you can't anticipate sometimes about how the breast is going to stretch out, how the implants are going to settle in, what's going to happen in 6 months. I don't fault anybody for it. I just want to do it in one. And then hurry up and wait. Just see what happens.
When you do it in one, do you have special post-op requirements for the patients?
Yeah, and don't lift and don't have sex and just follow normal rules for 6 weeks. They're just in a regular sports bra. I don't do anything with the band because I imagine that's going to be, it would be uncomfortable for me and make me feel claustrophobic. So I don't do that. Regular breast massages. Normal shit. Nothing, there's nothing fancy. Scar cream. Don't
I
get into
agree.
that.
I've seen.
Don't let anybody put their mouth on your nipple areola complex.
Oh my God. Preach. I've been saying that in so many episodes. Please keep their mouth off.
I see no mouth
a few months.
nipple areola complex, 3 months.
What have you seen?
And then I also want my patients to be in like some sort of supportive bra for 3 months because hands with folds can move a little bit, depending on the weight of the implant too. So I want everything to sort of settle and settle as best as possible. So wear a bra. You're adding weight. Let them heal where I want them to heal, not that they want.
Exactly. What have you seen with the nipple to mouth? What horror stories can you share with us?
Not from mine. This is another surgeon story, and I don't know. It's bad. I don't know if it's appropriate to share, but I think they were. I'm just gonna share it anyway. This is like an absolute horror story. So for me, I just tell people like mouths are disgusting. Like they have the worst bacteria, but the surgeon did reconstruction, mastopexy, everything was great, and they were in like the lifestyle parties, so they decided to go to an event, still with cherry strips on.
Oh my God!
And then engaged in some consensual adult activities, and then a week or two later, the whole breast is open, necrotic, and falling apart.
Oh my God!
Yeah. Don't do it. You remember, your wounds are so weak at 2 weeks. That's when your body's like eating the suture. So doing breast play, I guess we'll call it, is probably a no-no. The only thing that should be happening is massaging your breasts and washing them. That's it. Otherwise, leave the girls alone. Don't be putting up anything in that cleavage. Don't.
At least for how long?
6 weeks. Even then, I still wouldn't. So it's a lot. So at 8 weeks, your wounds are as strong as they're ever going to be, which is 80% of the strength. Technically, you should be able to like swing from chandeliers, but scars are modeled for a year. So I would be mindful of your activities. If it doesn't feel right, don't do it.
I say that all the time. If it hurts, stop. If it's pulling, stop doing it.
I tell my patients, 6 weeks comes along, like it seems like forever, but it comes along very fast. And I always tell my patients, I'm like, put a cute bra on for sex, but just leave it on, because there's going to be some hands and squeezing, and sometimes it's a little bit too much at 6 weeks. So if you leave the bra on, sometimes I can thwart a little bit too much play.
Sleep with it on, and also let's go into what's happening and why, because I've seen this in some before and after pictures where the scars just look so stretched, and I'm like, oh my God, this lady did not wear a bra at all during her recovery.
Scarring is like probably some of the most unpredictable genetic moon phase, whatever eclipse phase thing that still baffles me. So like I heal like shit. You cut me, I know I'm going to fit all the sutures, and my scars are going to like separate. And that's just the way I heal. And there are a lot of people that heal like that. But we live on Earth. We had gravity. Let's say for an augmentations, so now let's say 400 cc's. What is that? Almost a pound. You're adding a pound of weight to your breast tissue. It's going to stretch. Your scars are going to stretch. And then you're like, why did this happen? I got botched. You didn't get botched. You underwent like normal wound healing, and the conditions that the breast was left in, it was left with a lot of gravity plus a pound of implant. Shit happens.
Those scars stretch. We had Kristen from your office on the show recently, and she was telling us all about the different treatments that she's been doing for scars, especially like the CO2 laser and some other lasers that she was mentioning that she loves.
Moxie, Profractional, or Vis. All of those things. And then sometimes you just need to, I just need to cut out a soap brush. And then at least when I know when I do a scar revision in the office, even if it's like a tummy tuck of the area of like most tension, I know it's not healing as under tension. So I know we're starting fresh, and they usually can occur about 9 to 12 months after the original surgery. So you have to hurry up and wait. Because again, scars remodel up until a year. So you'd be very surprised how much time heals. And I know the patients are like, I'm in some of those groups, and they're like, the doctor just says I'm like really swollen and I just need to be patient. And I'm like, you do. Because you'll see the scars will remodel. And sometimes like that area would it look puckered or look weird, you're just like, hurry up and wait just a little bit longer. I see what you see. I also hate it. But just let your body do its thing. And just be a little bit more patient. And it's at that, when we check back in with each other between that 6 to 9 months, if it still looks stupid, I'm going to fix it.
And the scar revisions are usually pretty easy, right? They're like in the office, under local.
We're just chatting it up. Yeah, it's very straightforward. Doesn't require anything. It's usually, you don't even need cautery half the time because you have epinephrine in the local, so it doesn't even bleed.
So scar revision is going back in and removing the old scar, cutting around it, and making a new scar.
Correct.
Just so our girls can know. If you have a thick scar, a raised scar, maybe a scar that got very wide,
separated scar,
you can go in and cut it out and start fresh, start new.
Yeah.
Without the tension of tuck.
With prayers. And then obviously is what I think. There's always a question, why did it heal like that? And I go through all of those things. Like, was it me? No, because I know how to handle like tissue texture. Did I miss something maybe in there? Like a lot of Vietnamese patients, and they also match at size. And I'm looking all over their body. They have a tendency to keloid, and the keloid doesn't come till 6 months after.
Interesting.
It's a very long time, but once that keloid comes, that's it. There's nothing. I mean, I've injected steroids. I'll do like Botox. The only thing I found that works is a little bit of Kenalog at the time of closure, and that will help. And then just being very on top of things with like therapies, pressure, tapes, prayers, everything.
Sacrifice aversion.
I wanted to say it, but I've already said it 2 times, so.
It might work, though. It might work.
Mm-hmm. Mm-hmm.
So, Botox to the scar, I haven't heard of that.
There was this guy, Trumpet Ike, he teaches people how to do like ferning, a way to do filler instead of just like going straight and let's say filling here. He's like, well, let's do something called a ferning technique where you wrinkle around the wrinkle. And he was able to show us studies how it actually helps strengthen the collagen because you're making sort of like a grid that's going to support that wrinkle type thing.
Ooh.
So I'm all over his page. I took his course. It's great. Has it changed the way I inject filler? Yeah, if I inject it, yes. But I saw him injecting Botox to somebody's thyroid scar. And he showed the before and afters, and I was like, this is something so easy to do. You don't have, if you inject steroids, what can happen? The wound can open, the incision, it can thin, and especially in like African American, Vietnamese, you may get some changes in color of the skin that are not going to come back.
And indents. Like,
oh yeah.
Oh,
it looks like scooped out. It's usually from Catalog 40, not diluted, injected directly into the skin. Don't ask me how I know. But I was like, fuck it. I have a shit ton of Botox. Let me try it. It works very well. Very, very well. But you have to be on top of the scar. I do it all the time now. It comes in like, if somebody comes to me, one of my patients for post-op stuff and they need scar stuff, I'm injecting Botox, no charge, but just to help because I am so mindful. Because again, I scar like shit and I don't want that to happen to other people. And it's like you go through all this stuff and then you have like an ugly scar. I hate it. So I started injecting Botox into the patients that I know have a history of like hypertrophic or maybe even healing, and it works.
Oh, I love that.
Yeah.
I love that. You guys, I know this is why y'all love listening to this show, because you get to hear all of the stuff that Dr. Grunberg is doing in her office that's kind of new and interesting, and maybe you need to go see her for your scar. If you have a thick or a scar that needs to be revised, you know where to go.
And plus I like cutting them out. They look like worms. And then my favorite is I make the patients touch their scars and you give them gloves. I'm like, touch it, like pull it, tug it so you can see how it feels.
Oh my God, I want to do that. I
Nothing being creepy like that.
One, I love gummy worms. Gummy worms are my favorite candy. If y'all ever want to give me anything, I love gummy candies, gummy worms, gummy bears. I can imagine that it might feel like a gummy worm, like texture.
Because you'll go to cut out a scar like this and then it'll shrink out to something like this. And I always tell them, like, try to pull. And it's like, you never realize like how tough your skin is until you actually have it in your hand. And I'm like, try to rip it apart. I'm like, come on. And you can't.
That's so interesting. I want to do that now.
I'm like, I'll send you one in the mail. I'm just kidding.
I have a little part of my abdominoplasty scar that I hate, but it's very small. It's a very small part, but you know,
just let me zap it.
Yeah, I might come see you for it.
Yeah, let me zap it.
Okay, before I let you go, I want to talk about mesh and
love.
The kind of when to use it, how you've been using it in your practice, and how you've been using it for breast lifts, breast implants.
Let's start with implants. If you're using a huge implant, I have like a number in my head. How did I come up with that number? I'm going to say if you're over like 400 cc's, like anywhere from 450 and up, that's a pound. If you have shit skin and I'm adding a pound of weight to your breast, you need some support. That's it. You need some help because that pound, especially if you do something like in a dual plane, remember that bottom half of the breast does not have any, that bottom half where the implant is touching is just like breast tissue. It's going to stretch out. You need help. You're getting a mesh. If you're putting in like 250s, no, you don't need it. I think like I've done plenty of patients that have like smaller breast implants. I call them like Pilates boobs. They're perfectly fine years and years later. So I think about the weight and the gravitational pull and the mass of the breast for an implant. 2, if you're coming to me for a remove and replace, you're getting a mesh. That's it. We have to strengthen up I need like your remove and replace to last you as long as it can. By the time you're getting a remover and you replace, what do you, like maybe you got implants when you're 18, but whatever. My patients are going to be like 30s, 40s. You're going to go through menopause. Your breast is going to change. You need self-support. And mastopexies. Thin skin, 100%. Why? Or like larger breast mastopexies or the breast reduction I did today, I put in mesh. Why? Because she still wanted to be like D. That is a lot of breast. And again, you're going to go through changes. We still live on Earth. There's still gravity. So there was one patient that I did, and she taught me like so much. She was a massive weight loss patient. And I did it. She's needing a mastopexy. She still had like a D breast and a mastopexy. And I'm like, that's so good. What happened? She came in like 6 months, and I was like, this looks like shit. And what happened is she got something called like pseudotosis. So nipple areola complex is in like is perfect. So the nipples are the perfect height, but there was elongation from the nipple areola complex itself to what's called like the IMF. So the breast bottomed out. So then I'm like, oh, when I'm going in for like next surgery, I'm just gonna like wedge out a piece. So it wedged out like some skin and retucked it, and what happens in another couple months? Same shit. So the breast, instead of looking like a nice projected teardrop, looked like a flat burger. And that's not, nobody wants that. So she was like the case that taught me I need to be placing mesh into larger chested women who have, or anybody with a thin skin, severe amount of stretch marks. Mesh, 100%. I use Dalaflex. Love it. Have not had a problem with it.
I love to hear that. So, yeah, especially for our massive weight loss patients, I know a lot of my listeners who have lost a lot of weight, their skin already is kind of, they've already lost a lot of that elasticity in their skin.
Yeah. Same thing. So what's going to happen is the same thing that happened to the patient I did before. Any massive weight loss patient, unless it's like a small breast, and there's some that have small breasts, but I want it to look good for a long time, not a couple months, and then you're coming back to me, you're like, what is going on here? And I'm like, dude, I don't know either. But if I put a mesh in, incorporate the mesh to suspend the pedicle or the blood supply to the nipple areola complex or whatever sort of pedicle that you're using, plus I incorporate it into the closure itself. So you've got like a nice little hammock.
A little hammock. I love that analogy. It's like a little hammock for your breast.
And you're just like,
I love it here.
Yeah.
I love it. Do you do auto aug? I've had like 5 or 6 people just in the last couple of weeks ask me about auto augmentations.
Dude, all that is basically any standard mastopexy that I do. None of the tissue's getting thrown away, and you're just stacking the breast. It's basically what mastopexy. It's kind of like when people are like, if you do a breast reduction, are you going to be doing a lift at the same time? I'm like, they're the same. It's the same pattern. I'm like, no, I was just going to leave like your nipple down like really low and just leave it like
down by your belly button.
Yeah, I'm just going to take breast tissue off, but like leave it down. So I think it's kind of just like auto augmenting. It sounds really fancy. It's the best such.
Isn't there so many different terms and words and kind of marketing things that are, I see it all the time. Why are y'all asking me? It's because somebody out there is talking about how they do auto augmentations.
Yeah. I'm like, what is that? And I'm like, they're doing what I've been doing forever. I mean, not forever. They've been doing what I'm doing. I'm like, I don't understand. So now I have to be like, I certainly do auto aug, don't I?
You have to put it all out there, because even though you're doing it, like, for example, I know there's a lot of surgeons who, when they do their abdominoplasty, they automatically do flank lipo. Yeah. But there's other people who are like marketing it as body contouring, this special type of tummy tuck that leaves you with a curvy waist and doesn't let you boxy.
You're like, yo, it's the same shit we all do.
Surprise. I love that. You know what? I don't think I asked you on the last episode. Are you team drains? Or are you team no drain?
Drains. So I used to put a lot more progressive tension sutures in until I had a patient cough or like rip some out, and she had like a huge rectus, like a rectus hematoma. And because I was trying to work my way to get rid of the drain. And then I'm like, with the amount of like tumescent that I have, because most of my patients are getting like back lipo, VEOs, flip them over, thoracic lipo. So there's a lot of tumescent. Where is all that going? So for me, it's going in my drain, and that's like a nice little window for me to be like, to sort of have everything like come out. There's like some catharsis with it, because you get to see the color change from like, you know, blended punch to like a nice like sears or like light beer color, and then, you know, it can come out. But like Some patients put out a lot of fluid. Massive weight loss patients put out a lot of fluid. Where is that going if you don't have a drain?
Where is it going? It's collecting and underneath.
And I don't do you want to come in and have me drain? No. Just deal with the drain for like a week and a half to 2 weeks and that's it, and it'll be done. And you're drain all the way.
I love it. I'm team drain. Sis. I've had some surgeons on the show who are like team no drains, and I'm like, see if you can convince me, and I'm still not convinced.
Yeah.
Just because y'all don't do the drain doesn't mean you're not having seromas coming in.
There has to be seroma. You're also going to be like walking around with like a moose knuckle because all the drainage is going into your vag. That is not cute.
I want to point out, so if you're a massive weight loss patient, there's nothing wrong with you if your drain is staying in longer than what is anticipated.
3 to 4 weeks. There's a lot more fluid, and I think there's a lot more like lymphatic fluid coming out, not necessarily a bad thing. Massive weight loss patients, I tell them 2.5 weeks minimum for a journey for whatever reason. And swelling, spare tire swelling from your tummy tuck 3 to 6 months straight, and it'll eventually go away. Even like with fajas. Moose knuckle, 3 months plus. Like a whole, like child adult, you're to have a whole hoof down there. Just be prepared for it.
I see it in the Facebook groups. They're not ready. They're not prepared for it.
I try to be like, I try to tell people. I give them like a super cat now, or like have them like put something in there to present, but it's gonna happen.
It's gonna happen. Gravity's gonna pull. The fluid's gonna go somewhere, and it's gonna go
in your
travel down. It's gonna travel down.
Yeah.
Okay, Dr. Grunberg, I'm so happy I had you on the show today. There is one question I didn't go over. There's one thing I didn't go over, but I think it might need like its own episode. It's about different breast procedure incisions, like anchor scar.
Yeah.
Just just around the areola and then down, or just around the areola and then only in the fold. I've seen the craziest things. I saw one the other day. Somebody was marketing a scar-less breast lift. I'm like, how? Oh, it was around the areola, like the
periareolar.
Yeah. This topic, I think, needs its own episode.
Tried all of those. And then there's something like stem fast and shoe with like an anchor. Yeah, I've tried so many, and then at the end of the day, you go back to, there's a reason why the wise pattern like works so well. There's also scarless breast lifts where people are just jade plasma in your boob.
Have you tried it?
No. Morpheus, yes. Jade plasma. Then I'm going to tumest your breast. Then I'm going to like vaser it. On a young woman, I'm not there yet. Maybe on somebody who's like past menopause, but like I'm going to tumest your breast, and then I'm going to vaser, and then I'm going to jade plasma for a centimeter and a half of lift. For how long? You're just going to continue aging.
My question is about the scar tissue. How will the scar tissue show up?
So scarred. Oh, but you'll be in the sub-Q thing. So for a mammogram, they'll be able to discern.
Okay.
Well, hopefully you'll be in the sub-Q, but they'll be able to discern if there are any like calcifications or something that looks a little bit weird or a little bit off.
We talked, and we also touched on this a little bit earlier when we were talking about the different planes for implants, but
yeah,
the different incisions for augmentations, and they have
transax, periareolar, IMS,
belly button for spacing.
Yeah. No, I
swear to God.
I know one of my first assist goner is done their belly button, not done by me. So what I do, the one that's going to give you the least overall risk of capsular contracture, and the one that's easiest access point to go in and out of, and this may just be in my hands, is IMF.
Isn't it also the cleanest?
For sure. If you're cutting through, let's say, like periareolar and like breast tissue and stuff, there's going to be some BioBird in there. The most common complication for a transaxillary is going to be lateral displacement of your implants because the path of least resistance is just going back to where the implants were placed. So I fix those a lot. I call them gutter balls when when you lay down and it goes to the side. And then the one from the belly button, dude, if you want to go through that much trouble so people don't know you have implants, do your thing. Go for it. I don't do that.
I've seen probably like 10 years ago, I saw from an axillary incision where one implant was over the muscle and the other implant was underneath the muscle.
I know. Yeah. I mean, I've seen that from IMF incisions, so that does not surprise me.
Maybe it was two surgeons working on the same. Are you sure you're doing what I'm doing?
You know, like, do you see muscle above or below? Or it's like a surgeon and a first assist, or somebody who literally is just incompetent. Whatever.
Yeah.
Yeah.
We've seen some things. I'm sure you've seen some things.
There's a lot of like what the fuck moments.
Especially with breast revisions.
I just did a really hard one and I was so excited for her. I don't even know. I had to post the pictures and God bless her for letting me do it. Like, I don't even know what happened. Like, for the first couple surgeries, I don't even understand like what was going on. But she has two really good breasts and the nipples are alive, so that's a win.
Yeah,
and
you saved the day.
That's an absolute win. Yeah,
you deserve a story after that. You know,
yeah,
patting your
that's a hat the back moment type thing. We'll see how she heals, so I might have to take that back. But you know,
well, you did your part.
Yes.
Okay, so the other thing, you guys are not going to believe this, but Dr. Grunberg is going to be launching her own podcast.
I can't believe you just put that out there.
It's in the works. It's in the works. And you guys are going to love it.
I get such stage fright, but
it's going to be so good. If you guys want specific topics for her to talk about, if you have questions, if you have things that you want to hear, send me a DM and I will make sure to make a list for her so she knows what to talk about in her first year.
It's exciting and I appreciate you for helping.
You're going to do so good. Yeah, I already know you're going to do so good. You're going to have...
I get so nervous.
Being able to show your quirky personality.
I think so too. Absolutely.
And also talking about all of the things that you do in your practice that patients are looking for. Like, patients are looking for these types of procedures and different types of surgeries that they just need to find the right person to do it for them.
Some can take care of you. I think you're right. We have a lot to offer, and I'm kind of like in the weeds where I don't sort of like see everything, and I don't know what people don't know. Because in my head, I'm like, well, I talked about that, so this makes sense. So I think it'll be very helpful. I do miss a lot of the educating moments. I feel like I used to do that a lot more on Instagram, but we're now getting punished for everything. I'm in chronic shadow ban, so I can't even educate in the operating room anymore because I get told it's graphic violence, nudity, and stuff. So I think this will be a nice moment where we'll all have our clothes on, I think. Haven't gotten that far yet. And then we'll be able to discuss the surgery or like what happens behind the scenes, things like that.
Yeah, I think it's going to be awesome. I know my girls are going to be very excited to listen to it, and you're going to do so amazing. Before you know it,
thank you.
You're going to be having me on your show.
Oh, hell yeah. I have a lot of questions for you.
I can't wait. I got a lot of answers.
Good. Good.
Well, thank you so much for being on the show, Dr. Grunberg.
Thank you for having me.
If my girls want to come see you, where can they come see you?
I'm in San Antonio. Office number is 210-714-5390. Instagram is Dr. Grunberg. You can always DM me. It is me answering all the messages. I don't have anybody else on there. My office is in Chabonneau, in San Antonio, 16530 Huebner Road, Building 2.
Oh, beautiful. And she has a beautiful surgery center, you guys. It's amazing. So when you go see her, you can stop by her office and look at her office, and the surgery center is right there, right next to her. One-stop shop. Thank you for being on the show. I'll see you guys next time.
Bye.
So if you're listening to this episode and you're listening to the Big Butts No Lies podcast, you might be on your surgery journey. And if you are, and you don't know what to do, you don't know where to start, you've come to the right place. I am so excited to do one-on-ones with you guys. I've realized as I do them more and more just how valuable they are to you, not only because you get my expert opinion, I get to guide you towards plastic surgeons that we know are going to do a good job and keep you safe. Besides all that, I get to talk to you about things that might not even be on your radar, things that you don't even know are possible. But since we get so in depth with our conversations, and I really get to know what your dreams are and what you're really looking for with your body, I can tailor my recommendations to the surgeons that I know can help you achieve that. And taking the guesswork out of who to go to is invaluable. So schedule your one-on-one phone call with me. You can go to my website, go to the quick links, submit your information, let me get to know you, let me see how can we help you. You can get your own team. You guys, I have been working so hard behind the scenes to come up with a perfect way for you to have your plastic surgery and not only come out with beautiful incisions, but also feeling beautiful on the inside. So book your call with me and take the guesswork out of your plastic surgery journey. And don't forget, new episodes every Monday. I'll see you then.